This is a case of intumescent cataract with raised intralenticulaar pressure and a very fibrotic capsule. I make an incomplete main wound, approximately 1.5 millimeter, try and puncture the anterior capsule with the cystotome, and as you can see, it's a very thick, brittle capsule which is not being cut. Now use an MVR. I use an MVR to make a linear cut within the capsule, making sure that the intraocular pressure doesn't go down, because a sudden lowering of intraocular pressure can cause peripheral extension. Now, having done so, I use a Vanna's forceps to cut the linear cut horizontally with one perpendicular cut in the center to create a T-shaped opening in the capsule. Once this T-shaped opening has been made, now I proceed to enlarge my main wound after I put viscoelastic again to make sure that there's no sudden decrease in intralenticular pressure or intraocular pressure of the anterior chamber. Now I will enlarge the wound properly. Now use a McPherson forceps to use the two flaps of the T to create a capsular rhexis. Now the advantage of flaps are that I'm attempting in one area. You will notice that the capsule is very, very brittle, but still it does give way. Now I'll keep reducing the intralenticular pressure by ensuring that the intralenticular fluid, which is increasing the pressure, is leaked out. And then again, I flatten the anterior chamber by putting viscoelastic. You will notice that I try and circumvent around the fibrotic area. Now, at one particular point, the fibrotic area gets stuck up. Now, this is a tough situation again, but luckily for me, I have two flaps on the T. Now, in such situations, sometimes when your flap gets stuck at one point, you can start initiating the capsular rhexis from the other edge also after you've exhausted all means of extending the capsule. Now, as you notice, there is a thick fibrotic band of the capsular rhexis. Now, I will again put viscoelastic, flatten the anterior chamber, flatten the anterior capsule, and continue to proceed to complete the capsular rhexis. You will notice that the capsular rhexis is very, very brittle, hard, fibrotic. So I have managed to break it away, but still not managed to complete the capsular rhexis. Please do notice that at every point, I do put viscoelastic into the anterior chamber to raise the anterior chamber pressure more than the intralenticular pressure, while ensuring that the trapped fluid within the lens bag or the capsular bag is taken out. Now I am pushing some viscoelastic within the capsular bag to ensure that all the retained fluid of the intumescent cataract is taken out. This ensures that I have a better control on my capsular rhexis, and any trapped fluid behind the nucleus is also expressed out, which gives me a flat bag, a reduced intralenticular pressure due to removal of all partially absorbed cataract, and also now further enhances my visibility of that tag. Now I proceed to cut that tag from that area where it is extending and touching the rim of the capsular rhexis. Having done so, I have cut the whole rim, and now I realize that my capsular rhexis, though it is complete, but still has one sharp edge which needs to be trimmed, and also that the size of the capsular rhexis is very small. And since it's a small capsular rhexis which is brittle in nature, I may have an extension through that peripheral extension or that sharp edge of the capsule. Now again, I try and enlarge that small little tag to create a rounded edge in that area where I have a sharp edge of the capsular rhexis. But since the capsule is very brittle, now I resort back to the T technique by creating again a linear cut in the capsule, creating a horizontal linear cut. I will again push viscoelastic, and you can see the linear cut there. We will again extend it using a Vanna's forceps there. And now I have again two flaps. Now these two flaps again can be utilized to circumlinearly rotate these two tags and enlarge my capsular rhexis in this given situation. So in the end, I want to achieve the size of the capsular rhexis that I want. And I've also circumvented that brittle fibrotic part of the capsule, which was going to cause problem for me as I would have proceeded to do the surgery. Now the second tag of that T is now pulled and torn, and there I have completed the capsular rhexis and made the capsular rhexis large enough. Having done so, we are back in business. So tips to remember are: reduce the intralenticular pressure, keep making the anterior chamber pressure high by putting viscoelastic, never leave a sharp edge of the capsular rhexis, and feel free to use any instrument which you can use, which could be a 1R scissors, or MVR blade, or a cystotome, whichever works for you, to create that opening of the size of the capsular rhexis that you want. Now you will see, I will just fast forward this particular part of the surgery where we just proceed to remove this intumescent cataract, which was totally Margagnan's variety with a lot of liquefied, partially absorbed cataract within the capsular bag. And there you see it's a brittle, hard nucleus in the center. And we proceed to remove the nucleus, use slightly higher phaco power for this particular case. I have flipped the nucleus at the iris plane, and then I proceed to do the cataract removal in this particular situation. You will notice that after the cataract nucleus has been fragmented, the cataract can be easily removed. And there is a little bit of cortical plate behind the nucleus which can be taken off very, very easily. I'll just fast forward the particular step to show the cortical aspiration and the removal of the cataract in this case. You will notice that the capsular fibrotic part, most of the fibrotic part of the capsule in this uh, cataract has been taken off, and we can proceed to put the IOL the way we want. So use of an MVR blade in combination with the inverted T-rexes as described by me is very useful in such cases. You can not hesitate to use an MVR. The only thing you need to remember is you insert the MVR somewhere at the mid-periphery, not in the center, and also make sure that the anterior chamber pressure is always maintained higher than the intralenticular pressure, and you will get away with this surgery and with excellent results. So we hydrate the wound and you have a crystal clear cornea and the surgery is over. Thank you.